Hello, I'm back, and this is the second of 3 video lectures covering Chapter 4. In this set of video lectures, we'll be covering HIM roles and some of the other finer points of health record content, including making corrections, authentication, otherwise as signatures, and more. Let's have a look. When we talk more about the legal health record, we're talking about things that are not necessarily just paper or electronic. Ideally, we want healthcare organizations to have policies and procedures that define what the legal health record is, including any other record system, right? Especially as electronic health records are implemented. Many times we had hybrid record systems for a time. So you have to be able to address that. In other words, what is defined as the legal health record? And if you're using a hybrid record, how is that defined? The American Health Information Management Association has some strategies to maximize EHR data quality. This includes appropriate patient identification. If you have the right information, but it's going to the wrong patient, it's of no value. Another strategy is templates. Now we have templates that even get down to the different types of practices. It's not just a blank piece of paper where people can put things in as they wish. There's certain things that you see get tailored to the point that a GI consult will get into the history, what types of tests have been ordered, the exam, the findings, the assessment, the plan. All these are delineated out and go into a template. The copy functionality. Many times people like the idea of doing electronic copy and paste. It may not be the best idea because it can lead to people acting on information that's no longer accurate and relevant. Another area we need to have strategies and policies and procedures on is the corrections and amendments, right? In general, most electronic health record systems allow that anytime a record is amended, corrected, has an addendum, that will show who made the correction, what day, what time. Another strategy is standalone devices, right? There are all these different software programs that providers put on their phone, like Patient Keeper. What is the policy on that? All right. Are you just going to have these physicians walking around with PHI on their phone without uploading it to the hospital health record system? How are we going to deal with legacy systems, hybrid health records? And of course, my personal favorite is second from the bottom, the problem list. The problem list can be a problem as nobody takes ownership for it. And then you have all these things that are no longer relevant. People drag them into the progress note as you can on Epic and other systems. And then it causes a lot of problems. Last bullet point in this era of fires, earthquakes, hurricanes, and all these other natural disasters, what are your backup policies? How are you ensuring that all your information is backed up? So if something happens to your hospital and the individual electronic health record computer workstations go down, that the information is intact? How are you going to continue on with that? There's some general documentation guidelines that I'd like to talk about now that apply to all different health records. Each healthcare organization should have policies, and they should be organized to facilitate data retrieval. We see a lot more of that with electronic health records as things go into individual fields instead of just broad-based text so we can have enhanced reporting and data analysis. Only individuals who are authorized by the organization's policies are allowed to enter documentation in the health record, right? Access is typically determined by the individual's role. You don't want physicians or nurses to have the same level of access, right? Otherwise, you could have nurses potentially ordering diagnostic tests that might not be appropriate, right? So we need to have some sort of documentation guidelines about what individuals are authorized by the organization to enter documentation and in what part of the electronic health record. Medical staff rules and regulations should specify who may receive and transcribe verbal orders coming from a physician. Health record entries need to be documented at the time of services they describe are rendered. It doesn't do any good to have people write a progress note for an encounter that happened 2 weeks ago. And the authors of the entries should be clearly identified in the record. I recall when I worked at Stanford Medical Center, we had a signature chart. And that way, if we needed to, we could go through and determine who signed what in a paper chart. Another thing that's still with us is approved abbreviations. Only approved abbreviations and symbols that are approved by the organization and the medical staff bylaws are allowed to be used in the health record. An example of this would be requiring a leading zero in front of a decimal place to ensure that 0.25 is not misread as 25 or 2.5. All entries in the health record are permanent, right? So in a paper-based world, what we used to see is providers would draw a line through an inaccurate entry and then initial it and date it. Now, of course, we do this electronically. Instead of just their initials, it'll spell out their whole name and all of that. Any corrections or any addendum or additional information is added to an electronic record is identified as addendum. And if you look at an electronic health record screen, you will actually see an entry that has the words addendum written next to it, the name, title, date, and time that the addendum was made. An addendum is not the same thing as just crossing out something in electronic health record, right? Entirely different. We're not changing what was initially written, we're clarifying or we're adding to it. But in no way are we making changes to the original record itself. CMS has some individual documentation requirements. And these include things that entries need to be legible. No, I'm not kidding. That's really a requirement. Entries need to be complete. They need to be dated and timed. They need to be author identified, and they need to be authenticated, meaning signed in either a written or electronic form. And authentication is always a sticky wicket. Basically, we can use written signatures, initial electronic signatures. All these are acceptable, except they need to be clearly spelled out in the policies and procedures. CMS requires controls to prevent any changes from being made to the health record after the entries have been authenticated. So in other words, you can edit things as you wish, right? But once you sign it and submit it, any corrections will go in as an addendum. Auto authentication is something that is rather interesting. And this is a procedure that has dictated reports to be considered automatically signed unless the HIM department is notified that there's an addendum coming within a certain time frame. People have mixed feelings about this, right? Because it's basically encourages things to move along at the potential risk that you might have inaccurate information being approved. And again, health record information typically has two broad types of information. They're either clinical or they're administrative. Each person has to have a health record, right? Sounds kind of easy until you think about twins, obstetrics, some of these other things, right? If you think back to when you took ICD-10 CM coding, you can have a maternal condition, pregnancy complicated by, and then you can have a newborn condition. So you can have pregnancy complicated by maternal diabetes, and you can have newborn diabetes, right? And the content on the documentation will vary by the setting. Behavioral health will have different needs than acute care hospital, but both will have clinical and administrative data. When we use the broad term of inpatient health record, we're talking about a record that's compiled when a patient stays overnight. A lot of times these are medical or surgical cases, admissions, if you will. And these records tend to be more complex, right? If you think about it, we have nurses, other allied health professionals. Many times if people are being admitted to the hospital, they'll have multiple medical issues and so on. Here's an example of some things that you see in inpatient documentation. First of all, we'll start with the third bullet point, or the second, medical history, right? A lot of times people in the trade will talk about history and exam, history and physical exam. But basically, these are required documentation requirements for all inpatient admissions. We'll also have the clinical data, right? Why did they admit the patient, right? And this gets into medical necessity, which we've talked about in other courses. We'll have all orders for any type of therapy or diagnostic test. Nothing happens in the hospital setting unless a provider orders it. Even diet needs to be ordered, right? Clinical observation, right? Subjective, in other words, how the patient looks, what have you. We'll also have discrete digital findings, what somebody's blood pressure is, what size of mass is on surgery, and so on. We'll have surgical procedure notes, commonly known as an operative record. And this is where the surgeon writes what the patient came in for, why they were there, what procedure they did, how they did it, and how the patient left the operating room. Frequently, as we talked about earlier, patients have more than one problem. This is where consultants get brought in, right? And they'll do an inpatient consultation and write about what their findings are. We have discharge summaries, which is kind of like the abstract summary of everything that happened to the patient while they were in house, instead of going through and having to read each progress note, each lab, and what have you. Related to discharge summaries is the patient instructions and transfer records. So if somebody is discharged to a long-term care setting or a SNF, they'll have what medications they're supposed to follow up with. If somebody's discharged home with a diagnosis of heart failure, they'll be asked to weigh themselves and so on. Now, again, we talk about medical history. We're talking about this same kind of things that you are familiar with from HIM 273. Think of it almost as kind of an E&M coding. We have the history of the present illness. We have the exam, right? We have a chief complaint. We have why people come in. If their social and personal history contributes to the issue, then we'll bring that in. We'll review the systems, do the exam, and then based on the exam, the physician or other provider, it says physician here, but it's the same process if it's a PA or a nurse practitioner, they'll make an assessment based on what I've worked up and reviewed. I've ordered these diagnostic tests. I've examined the patient. I reviewed the outcomes of the test. This is what I think they have. This is what they have. And then we'll go from there. We'll order meds. We'll schedule them for surgery, what have you. And again, going back to our earlier comment about ordering, nothing happens unless it's ordered. Sometimes we'll have what we call standing orders, right? So for somebody that has cardiothoracic bypass surgery, right? They'll have standing orders based on subject matter experts on what they're going to order for these patients unless otherwise indicated. And again, we talked about progress notes, right? Unfortunately, per the third bullet point, we don't have everybody being discharged home healthy. Unfortunately, sometimes we do have patients dying in-house, and this is sometimes called a death summary. Think of a death summary as a type of discharge, if you will. And if somebody dies in-house, you will most certainly usually have a request for an autopsy and basically a post-mortem, as one pathologist I worked with called it, a post, where they write down what the findings are, evidence of disease, and so on. Another thing we see in the inpatient records noted are the vital signs, flow charts, and the diagnostic and procedure reports. Let's take a look at those one at a time. Vitals, of course, are your blood pressure, right? Temperature, respiratory rate, all those different types of things. Typically, those are kept on hospitalized patients pretty consistently. We'll also have flow charts, right? As one person said, think of a flow chart as I's and O's, ins and outs, right? When I worked at Children's Hospital Oakland, the neonatologist was always interested in what the I's and O's are on preemies, right? How much the diaper weighed, kind of an indicator of what's going into the baby, what's coming out, are they dehydrated, and so on. When we have surgeries done, we have, in addition to the operative report, we have an anesthesia interview and an anesthesia report, and then a recovery room report, right? If you've ever had surgery, this is where you wake up and they do some preliminary assessment of you before they send you on your merry way. In addition, we have the pathology report, right? So anytime tissue is taken out, a specimen is sent to pathology, and each specimen gets a unique identifier so they can determine whether a specimen is showing evidence of disease, evidence of cancer, and so on. We also have consultation reports. So if somebody's seen in the emergency room, they have a knee injury, right? They bring in an orthopedic consult. Those get compiled along with the rest of the inpatient record. And the last slide I have, of course, this comes at the end, is the discharge summary. It's a summary. It's an overview of an encounter. A lot of times, if a patient is in-house for less than 48 hours, such as in the case of a normal newborn delivery, they'll do what they call a short form discharge summary, right? Where it'll just describe why the patient came in, what the course was, why they were in, and so on. Discharge summaries should include documentation of patient instructions, or if they're transferred anywhere, where to, how transferred, and so on. And that's all I have for you. Come back for the very last video lecture on this chapter, and we'll finish up chapter 4. Bye now.